Hello. Hi, everybody. This is going to be our last session for today. This is session 9, digital innovations and delivery of health services. As people trickle in, I'll start announcing the speakers. The session is going to be chaired by Professor Otonu Rabani of the University of Dhaka. Oh, yeah, if everyone can slowly be seated. The first presentation is from Dr. Sulaiman again, and then who's going to be followed by Professor Farzana Misha and Dr. Javier Enrique Guerrero Castro, who's joining us virtually, BRAC University and Universidad de los Andes, respectively. And then the last paper is from Asadur Rahman Nail, Country Director of Simprints. If everyone can remember to speak into the microphones, and yeah, hand it off to the chair.
Thank you. So this is the last session of the day. So still glad that we have a decent turnover. This session is about digital innovation in health. Technology has played a very important role in promoting health, MRI machine and whatnot. But now we are living in a time where digitization and technology can probably play a lot more role than it has played before, not only in the clinical setting, but also in the community and population health setting, which kind of what my forte has been for the last couple of years. I don't have much to say, and I should hand it over to our respective speakers today. I'm really glad to see the lineup because they will be touching upon many different aspects of digital technology and how it can improve health outcomes in terms of delivery, in terms of keeping track of individuals within a population, in terms of direct delivery of, for example, mental health intervention directly to individual beneficiaries. So on that note, I would invite the first speaker, good old friend Murshi Sulaiman, to start with his talk.
Let me stand because I'm having a little health issue on my neck, getting old. So it's easier to see it that way. Right, I know we are over the time, but I do have a lot of slides. I'll try to zip through some of these. And let's just dive into it right away. I am going to talk about an app. We call it, for now we're calling it Komsha. It's a Swahili word. It means let's do it or to activate. I don't know if if that's what, if you put Komsha on Google Translation, that's what it'll say, to activate. But it's not that. The meaning is beyond. That's the limitation of NLP that we talked about earlier today. It means more like in Bangla, if I can say, like chol, chol, chol. That type of a thing. That let's do something. So what's the idea behind this? I'll zip through this. It's just a part of a multi-country study. We are in a phase of impact evaluation in South Africa. In Uganda, we are doing a feasibility study. We're calling it feasibility study, but take it more as we are really trying to make this app work before we go to the evaluation phase. And we are facing a lot of challenges and we are trying to overcome them. And it's not a study where we'll do an assessment and say, oh, this is feasible, this is not feasible, this can be feasible if and but. This is more about getting our hands into it and see if we can make this idea work. And that's because this is not the first time we are thinking about trying to address mental health through gamification. This is not new. This has been tried. Clinical trials have been done, mostly in the UK. Our partners from the psychiatry department in Oxford University also have some local clinical psychologists involved in this research. They have done some studies in UK, mostly with postpartum depression, like how to treat postpartum depression through app-based solution. And this presentation is going to be mostly about the app. What is it, the app, how we have come up with, what are the ideas behind it. But before going there, a broad sort of idea of what this behavioral activation mean. So if you know the sort of psychology and economics literature, there is a, like we in the economics, we call about aspiration failure. You don't aspire much, therefore you don't get much. Kind of the hope, the science of hope. These are new words that are coming up. But it comes down to something simple like this, whereby you feel low, that makes you stop doing things that matter. Therefore, you get less out of life and you get caught in a kind of a vicious cycle. Now, in mental health, when most of the intervention that we talk about or we are aware of, like cognitive behavioral therapy or the therapist, we all know that about the therapist, even though we have not taken their services. We know this is the guy who sits around, listens to our pathetic stories, and all they say, and we pay them for that, right? That's kind of the psychiatrist. But the important part of that is you're talking to someone who is non-judgmental, and whatever you're saying is confidential. That's the service they're essentially giving you, because they don't give you any solution. What does that do? That makes this vicious cycle break through how you feel. That makes you feel different, and therefore you start to break this vicious cycle. The behavioral activation, on the other hand, tries to address this bit. Stop, because when we are low, we don't do things that matter. The idea of behavioral activation is don't think about it. Just do something that makes you feel good. It's something that we can apply in all our lives. It's not just for depression patient. There are days when we feel low. And sometimes it lasts a day, sometimes a week. And there are ways to get out of it that we all can sort of apply in our life a little bit here and there. Think about your partner. You may have tension with your partner. Without trying to talk about in this feel low and sort it out, maybe do something that makes you feel, both of you feel good. And that's how you can break the cycle. Go for a coffee, to a movie. That's the whole idea about this behavioral activation. So I think I've taken enough to sort of pitch it. We have been doing a lot of formative work, mostly qualitative, and our research team, sometimes we don't even know each other. It's really a team of over 30 people in 3-4 different countries. But as we are trying to develop this app, we have been also working with hundreds of sort of stakeholders, participants, etc., etc. So what is this app? This app is essentially open it and it runs you through a few stories. You can earn points, any game feature that you have that makes people play. You can track how you have gone, but I'll come to where it comes to real life. But the whole idea is through gamification, that's the hook. We try to nudge people to think differently and do something about it. Now, when I first came across this whole initiative, I was skeptical. What is it, this gamification, this storytelling, where you have these stories, you zip through stories. We have two stories. One is a song contest and the other one is a football contest. So someone opens the app, picks a character, and then it walks that person through a series of stories, 6 episodes in each. So I was like, who would play these games? It doesn't look like a game to me. But then I realized this is, first of all, is fairly common. So that's something reminded me I'm kind of olded. But the other thing is, I realized this is actually a bit interactive version of comic books, kind of reading comics stories. So it's just an interactive version of that. But the important part that we try to sneak in is this bird. So you go through so this character goes through a journey. When they pick the song context, they have to prepare, they face challenges, and then comes into a situation where he says, she feels like we are going to embarrass ourselves in the performance if we have worse song there. Really stressed out about it. And now this little bird, it pops up in different places. So this bird for me is like, You know, the Jatra old age, there used to be Jatra, and the common character used to be this big guy in between sings a story and tells about. So that's basically the idea here. Like, don't feel so shy or so down. Think about something. What else can you do? So that's how these stories runs. Um, and then on different days as they play, we also try to monitor their modes. So these are kind of data that we are gathering for analysis. And then they also can track their modes, and they can also find out themselves what made them feel better or worse. These are sort of some features: password protected. There is a tech hotline. So if at any point of time they feel really depressed, doesn't have to be about the app. There is a hotline there where they can call, get some support. Um, and there is, comprehensive risk management protocol. These are all the ethical aspects we have. Um, these are just personalized character. They earn points. I think I've talked about all of those. I don't need slides, I guess. Right. So that's the whole app. And at different stages of the app, the bird, this Vivek, asks the person to think about something in their real life that they are struggling with or they are not entirely happy about, and then asks to make a commitment or a goal for herself. And then they can track, like they say, like, I am doing bad in my math, so I'm going to do math exercise for at least an hour every day. So they set goals like this, and they can put these goals in the app, and they can track how they're doing on this. And we also have some what we call peer mentors who periodically call them. Since this is a feasibility study, we have a very big team. We can afford to, I think, at this stage. We are not thinking so much about scale or evaluation at this stage as yet. We have peer mentors who call them up every week to see their progresses, both on using the app as well as how they are doing all these personal goal setting, all of those. And then, of course, if there's any technical glitches, obviously there are always. We tested our app on one type of phone, it doesn't work on a different type, and it was on a Samsung, and even on the Samsung, the screen size on 8-inch versus 460-inch, it doesn't work, all of that. So we try to sort of keep troubleshooting as we go. So there are sort of various components of this whole behavioral activation through gamification, and I've talked about all of those. But the ultimate objective is basically, at least for those who are literate, who can enjoy such a game, can they use it not only for sort of addressing their depression or severe anxiety, but also in their daily lives. And actually, when we were coming up with all these stories, I learned a skill or two here and there from working with the colleagues that I can apply in my own life. I mean, these are all essentially soft skills. No one teaches us like that anymore. We are talking about it more for adolescents, etc., but trying to teach all of these soft skills through this app. I think I'll stop there.
Thank you. So how do we still have some time, right? Like his allotted time? Yeah. So any clarification question at this stage? Yes. It needs to be quick. And I'll be the judge of whether it's a clarification or not.
So my question is the role of the peer mentors. Like, are they working like as a counselor or like as a friend? Because if you see the context of Bangladesh, like in recent time, many psychological support groups have been arrived in social media or in apps, but they are not non-judgmental. Okay, so how they're like going to treat and how they're like going to find the adolescence period problem and the male issues. If I address the male acerature issues? Is there any kind of possible way they can address this issue and can help the support groups to like reduce that items? So yes. And also one question I must ask, that how can we bring this in Bangladesh? Like how can we collaborate with this thing? Thank you.
Can I perhaps you can just touch upon the first question, like who are the peer mentors? We can talk about the Bangladesh part perhaps in the open discussion session.
Right. No, that's a very good question, because I mean, peer mentor doesn't go with the app. Like when I started talking about app, probably you didn't think that this will also have a peer mentor. And peer mentor has several elements of it. So as part of the feasibility study, some are basic technical. Do they have issues of charging their phone? Do they have issues with the app, and etc.? So if there is anything that comes up, they are the ones who tell us and we try to fix it. So that's kind of basic. Then in terms of being peer mentors, so they're essentially a bit older adolescents. So the peer mentors that we only have 4 of them. They're of the age of early 20s. They've crossed the teenage age. So they're like elder brothers and sisters, which is typically what the peer mentors are if you think of any adolescent development program, who are the sort of last mile training providers. So these are people of that same characteristics, but their role is not about therapy. So on that part, their role is twofold. One is if they detect any cases that needs to be flagged, we have professional counseling, they refer them. So that's kind of from ethical perspective, whatever we need to be mindful of that. So they just raise flags. They don't do any counseling. The second job is, since this is not about counseling or making them feel, this is about behavioral activation. So they keep reminding them. So if you're feeling low, they can talk to that person, but this person will advise, can you do something about it? Or do you want to talk to someone about it? So that's kind of, we're trying to not make it too much about the feeling part, the therapy part.
So let's move on to our second presentation. We have 2 speakers, my colleague from JPG, Farzana Misha, and Javier Castro. Are you online? Can we hear from you? Just to ensure that you're there.
Hi, yes, I'm here. Thank you.
Javier. Welcome virtually. So Misha and Javier, you have 15 minutes. Feel free to divide any way you like among yourself. No, I think you have to turn. Yeah. Now.
Can you hear me now? Yes, great. So is it okay if I stand there? Because it's very difficult to.
Yeah. I understand.
So, hi, everyone. Thank you, Autonom Bhai. So today, me and my colleague Javier will be talking about the path to inclusive digital health rights, and we will share perspectives from Bangladesh and Colombia. And as you can imagine, I'll share perspectives from Bangladesh and my colleague from Colombia. So time is not our friend, so I'll try my best to finish it in 7 minutes so that he gets 7 minutes as well. So first of all, why digital health and rights? So throughout this conference, we did hear about digital health, we did hear about the digital financial inclusion, but I don't think we have talked about digital rights yet. So either it's been taken care of or it's something we don't worry about at all or care about at all. So first, let me tell you why digital health. As you know, digital health has the potential to reach low resource setting and ensure effective healthcare delivery. And the biggest example was during the pandemic, when we saw exponential growth of digital health services. However, there are threats with privacy, equality, and autonomy regarding dealing with health data, and sometimes even sensitive health data, for example, data on sexual and reproductive health and rights. There are some groups that are at risk, mostly marginalized groups like people living with HIV, migrants, women, LGBTQ population, where it can be difficult for them to share health information on digital platform. So just to give you a quick overview of the project, this study is a part of, we call it DRAG. It's basically a participatory action research project. Under this, we are reviewing the existing legal and policy frameworks, their governance system, how they are addressing human rights. And then we are conducting ethnographic field research and also digital ethnography on social and digital platforms where health information is being shared. And from the findings from the findings of those two, we will develop some policy recommendation, and the plan is to advocate and raise the recommendation in health policy at national and global platform. So let's quickly go through Bangladesh's digital health journey so far. So Bangladesh's digital health journey started in 1999 when CRP first initiated telemedicine services. And after that, till 2008, there were very few initiatives, mostly taken by Grameen Communications, Grameen Telecom, and Grameen Phone, which involved mostly, like call centers or telehealth initiatives. The big push came in 2008 when the current government announced Digital Bangladesh and Vision 2021. And after that, in 2009, DGHS started district health information software where at district level you collect health information. Then in 2015, we have Shastobatan Health Call Center. And the biggest push was in 2021 during the pandemic when the government launched the Shiroka app for vaccination. So under this study, we reviewed a number of, to be more precise, 25 digital health services that are available in Bangladesh. So while doing that, what we realized, like there are three types of institutions that provide such services: NGO, government, and private. And the types of services mostly include consultation, audio, video consultation, sharing information on social media, social platforms or digital platform, and then services. And while we were reviewing it, what we found out is the authenticity and accuracy of information provided. That's something we have to be concerned of, because there is no guarantee that this person is sharing the right information. Also, some of them reaffirm common myths and misconceptions prevailing in our society, and these are mostly regarding SRHR. There's lack of language options. Most of them are in English. They lacked interactive tools. So after a while, it can be quite boring and you might not like to continue that anymore. And also there are options for binary genders, which excludes people of other genders from the very beginning. So now let us take a look on the legal and political framework on digital health. So here you can see the articles that kind of, are for digital health and rights in Bangladesh. I will not go in detail, but as you can say, they talk about fundamental human rights, health being a fundamental human rights, removal of disparity between urban and rural. The reason we put it there, because as we are aware, there is a gap there's a digital divide, I might say, when it comes to urban and rural areas in Bangladesh. And then we talk about legal framework in privacy and data protection. Under this, we have the Right to Information Act 2009, where you can ask for any information, maintaining your anonymity at a reasonable fee. But then there are two more regulations and acts in progress. One is regulation for digital, social media, and OTT, where the service providers will be held accountable instead of any users. However, the authority will have power to block information in case they feel like it can do harm to it's of national security or anything. Then we have Data Protection Act, which is also in progress, where it proposes to safeguard personal data. But again, in this, it grants authorities access to encrypted communication on personal devices. I guess that includes WhatsApp as well. Now let's look at a legal and policy framework in ICT. So we have the ICT Act 2006, which promotes privacy and confidentiality of digital information. But then again, the section 57 of this, as I think most of us know, it can prosecute a citizen for posting something obscene or something hurting religious sentiments, which is under a lot of debate as well. And also in contradiction with the previous regulation for digital social media and OTT, where service providers should be held accountable instead of end users. So that's something we have to see how this is being resolved. Then we have Digital Security Act, which also is under a lot of debate. And I've put some national policies like the National ICT Policy, Education Policy, and Youth Policy, where all of them, they include ICT and digital platforms being used to store or manage data, or and in to some extent carry on activities. Now looking at health and digital health, like policies and laws involving health and digital health. So we have our National Health Policy 2011, where it urges to increase health coverage through e-health and telemedicine. Also emphasizes on ICT in health service, using ICT in health service delivery and management, and also a number of ICT-based health information structures, as you can see, e-governance, e-health, telemedicine. And then we have Bangladesh population policy, where it does mention using digital information technology, but that's mostly for integrating a collection of information on that data, but it does not mention anything about digital health services. Lastly, we have the National ICT Policy, where it precisely targets digital health services. So as you can see, it proposes to ensure portable electronic health records, clinical decision support system, also massive open online course for health personnel. And the last one I find quite interesting, proposed to use augmented reality and virtual reality for nursing and midwifery education. So just to bring all together gaps and challenges. So obviously there's a need for digital literacy for health service provider at the field level, digital divide between male and female, and also urban and rural areas, and making sure the rights are protected for the marginalized groups. And also there is no, till now, there is no regulations for digital health startups. So I believe I can even start a digital health app tomorrow and provide services. And health data is yet to come under one umbrella, even though the government is taking lots of initiatives to put data together, but there are some bottlenecks. For example, data sharing mandates between public and private health service providers. So there's this ordinance 1982, under which the private hospitals or clinics, they are not obliged to share health information with the government. So there was a change in that during the first dengue outbreak. Then the government said for infectious diseases, the private hospitals, they have to share information with government. And that was very helpful during the pandemic, as you can imagine. But till now, we don't have an ordinance that would make them obliged to share all kind of information. And throughout the conference so far, yesterday and today, we did talk about unique IDs, because if you use an ID 18 years old and less, they will be out. But then again, birth registration, it can be quite tricky. My personal experience is one of my daughter was born in Uganda, and I couldn't have a birth registration for her in Bangladesh, because in the list, Uganda is not there. So as if Bangladesh thinks nobody can be born in Uganda and come to Bangladesh. But yeah, that was a big mess. And also use of universal terminologies, because when you are you're putting data in the system, if you don't have a guideline for universal terminologies, it can be very difficult to merge all data set. For example, in one district, I'm saying TB 32 patient, in another tuberculosis, and another district tuberculosis with a different spelling. So then it becomes very difficult to put it together. And last but not the least, Still, we don't have national digital health policy. So good news is there is a national digital health strategy that's being drafted, and we've been hearing that since 2020. It's been 2 years. We still don't know what's in it, what's not in it, but let's wait and see till it comes out. So I think that's all for me. I'll hand it over to my colleague Javier. Javier, over to you.
Hi, thank you.
Javier,
I think I have like
sorry, but if you can just keep it within 8 minutes, so
yeah,
we are giving
I think
time for the
that's
whole.
what I was thinking. Like I have like 5 minutes or 3 or something like that. But thank you, Misha, for inviting me to the conference. I would like to point out that I'm also part of the project, drug project, digital rights. We are doing a multi-country research in which we are trying to compare different digital frameworks and also how people uses technologies for health. One thing that is interesting probably, and that I would like to start with that, probably in the next slide, is something that Misha finished with, is the digital divide that still exists in the countries. In Colombia, we actually have 24% of the people using internet and actually having broadband and really good internet. But it seems like most of the people of the users of internet is concentrated in urban areas, which is important when we are talking about digital health and digital health rights. Also, there's another big divide here. I don't probably should be in the next slide, but that 19% of the people, of the women, sorry, are actually lacking access to infrastructure or digital infrastructure. So this is an important divide that we have, because probably also because we are framing this study in terms of gender, and that is an important issue. So what we have here is that the internet is getting cheaper, but not cheap enough
Sorry,
for.
Javier, just a second. Can you just leave it in here? I mean, you don't have to play around with it anymore.
Yeah.
Javier, please.
Yeah.
Not
Sorry.
to you. We were having some glitch here. Sorry to interrupt. Please go ahead.
No worries. No worries. Thank you. So as you see, we're having like a really good growing recently of internet, but the divides still exist, and there's two important digital divides. One is gender. Still, 19% of women don't have access to internet, and also internet is mostly based on urban areas. Rural areas still have like really slow internet when they have internet, which is important when we are talking about digital rights. Also, our research is focused on migration, because we have a big issue with migration. I'm just gonna try to skip really fast on the laws, probably in the next slides. What we're trying is to compare different countries. We're comparing Colombia to Bangladesh, which was really a challenge in the beginning, but we found really interesting stuff. I'm going to try to mention that. We also have this regulatory framework, and let's start with the Constitution. Our Constitution obviously expresses the right to information, the right to actually to live. And there's a really interesting thing with our Constitution, is that our Constitution doesn't really talks about the right to health. It talks about the right to have a really good quality of life, and etc., but doesn't really talks about the right to health, which is all in a different law. We still have developing like different legal frameworks for people living with HIV, which is also one of the focus of the drug project, trying to understand how people living with HIV manages to face and challenge digital infrastructures. We have since 2009, we have in 2010, we have developed frameworks to talk about telemedicine and remote, the uses of remote services for health. Also in 2012, the right to privacy online, the right to access to information, transparency, and just recently, and this is really interesting, with the pandemic, we have been talking about the national digital policy, which is very similar to what is happening to Bangladesh with Bangladesh. So just in 2021, we have an ethical framework for artificial intelligence and the use of artificial intelligence in medicine. Just, I think we can briefly just go to the summary and to the conclusion. So we can just try to say we try to compare Colombia to Bangladesh regarding this, and we found really interesting stuff. We actually have a document that hopefully we can share with you at some point in the near future. It's finalizing, it's in production now. We try to compare the similarities and the similarities between Bangladesh and Colombia in digital right, and we found really interesting things, like, for example, data protection, in which in Colombia we have a law about data protection, but it have a really big loophole, which I think is something similar that happens in several countries, that when data is considered sensitive for security and national security, government agencies actually can access. Another issue with Colombia, even if we protect personal data, is there's several loopholes in the when data is aggregated. There's not really like clarity about what happens when data is aggregated. It can be sold, can be transferred. So that's something that we find really worrisome. So finally, I think, just to summarize, I could say that there are some similarities also regarding developing digital infrastructure, with both countries actually growing rapidly, but the digital divide persists, both between rural and urban areas, between genders, in both countries. The divide is related to access, but also knowledge, which is really interesting that we're trying to capture doing more qualitative research. Both countries face a combination of gender stereotypes with respect of relationship with women and technology. Here in Colombia, there's still like a big stereotype that is also reflected obviously on the access to digital technology. I think gender income gaps is also an important issue, which is enhanced by infrastructure injustice, as we are calling that here. I think while, just to finish, while Colombia gender-based discrimination is prohibited, there are still violence against LGBTQI communities. Finally, probably just something about privacy and confidentiality. I think just to again stress on the issue that even if we have laws about breaches of data, there are a lot of loopholes, and mostly related with law enforcement. Probably we have time at the end for questions. I know that was very brief. Thank you.
Thank you, Javier. So for this one, probably you can hold on to your questions. And I want to go directly to our third and final presentation. We have Asadur Rahman Nail from country director from Simprints, who happens to be also the country director of this organization. So, please, by all means.
Yeah, I guess I'm audible. Thank you so much. I guess in the middle of all the researchers, I am a bit of implementer. So we'll be sharing an RCT that we did. It was a longitudinal study, quasi-experimental, on a community health program with BRAC. So before that, I think a little bit of background is required. Why suddenly we try to use biometrics for health service delivery? So this is a problem that the world has. Reliable ID is a very big issue, not only for the refugees, but also for marginal people across the world. And the scale of that problem is global. If you look at the examples, okay, some of these are, okay, it's not coming properly. But anyways, in Chad, in Nicaragua, in Pakistan, even in Bangladesh, we have challenges with um, proper information and lack of data, uh, let's say alignment between different organizations. So what we are doing to solve it in Simprints, we are trying to solve this problem using digital IDs based on biometrics. And so who are we? We are a non-profit technology company from Cambridge University, and our mission is to ensure that global development becomes more transparent, more effective, more efficient, and every dollar, every public good, every vaccination reaches to the person it is intended to. Okay, a little better. Thank you. So, um, so we have developed a system, and this is something designed considering the most resource constrained areas of the world where there might not be any electricity, there might not be any um, internet, even mobile network connection. So a simple Android phone can be connected with our solution, and then eventually it can link medical records with biometrics. So every time someone's getting a service, can be verified through the biometric solution that the person is actually receiving the service. So it's a very straightforward solution because the complexity is at the back end, because there's a lot of engineering went into this, and there can be different modalities. So we have global partners. Gavi is one of our biggest supporters. We are in partnership with NSC, ARM, Ministry of Health in Ghana is one of our partner, and we have worked with World Bank, and we have also received the Mission Billion Award, and BRAC is also again another partner of ours. And this is our global footprint. In 16, 17 countries we're working, and now we're coming to Bangladesh, the study we did. So maternal and child mortality turns out to be one of the biggest challenges, even though Bangladesh did really good in reducing the rates, but in urban slums, the rates are still high. When the study was done, we were using data from 2012-13, and the number was really high. So for that, BRAC had a very interesting program. It's called Manushi. The beauty of the program was it worked with the um, two layers of frontline community health workers, and it went door to door to provide the maternal and neonate services, helping them to adopt the behaviors that are required to adopt, and then establishing linkages between government services and NGO and private sector services. And there were some really interesting and strong results out of this project. However, the project faced certain challenges. One of those challenges were identity. The reason was the people who live in the slums, they are subject to a lot of marginalization, eviction. There can be also other issues, even fire. So they frequently move around from one place to another place, and it's very difficult to detect where someone moved from one place to another place. And what it uh, eventually contributes, it contributes to duplicate records, it contributes to missing persons, who fall through the crack. In fact, in one record we have seen that one Yasmin Begum, she was enrolled as Yasmin Begum by 4 different service providers, and each gave her one ANC. In Actually, she was only one person who received 4 ANC, but because they did not have proper identifications, they could not be cross matched. And we have seen that this type of duplication can go up to 10-12%, and it costs a lot, maybe $50 or more to correct one of these records. So what we did, we introduced our solution in parts of Manushi project. We took 4 slums and 40 community health workers, And Simprints ID was integrated with BRAC's eHealth platform. And the objective was to link biometrics with medical data and see whether it can make a difference. So this is how it works. You can see someone's coming to provide a service, and the person is being biometrically verified, and all the medical records come up. So it really doesn't matter where she is moving from one slum to another. If she is within the coverage range, she can be identified, and her records will come up every time. And again, it brought it brought in so many insights, especially for the managers, because the system is as such. We don't only take biometrics, we also took timestamp geolocation. So the managers exactly knew who's delivering service to whom and where and when. So that made a big difference. And the monitoring changed. It became very focused and effective. So then we did a longitudinal study. So it was a quasi-experimental design, and out of 12 slums, we took 4 slums, and the 4 where Simprint solution was used, and the 4 uh, considered as control. So we took 100 mothers from each of these slums, and it was totally random selection. So we collected baseline data from December, January 16, 17, and endline data in June 2018. So let's look at the findings. What we have found? We have found that 38% more ANC visits occurred in the control group. We have also seen 27.64% more women had complete birth plan. 8.7% had a skilled attendant at birth, and 19.19 more newborns received PNC services by a trained provider, and 12.77% more received their recommended number of PNC visits. So all the indicators that we looked into for maternal health and neonate health outcome improved. Now, again, apart from this, Judge Business School in Cambridge did another analysis and in DID method. They also found the similar things. And you see, almost 96% beneficiaries found that they never had any challenge with the biometrics system to identify or to get their data or to get the services. And there is no magic. The reason is very simple, because it made the whole thing very transparent. Yeah, it made the whole thing very transparent. And if you can plot the data on the map, you can exactly see the path of the service provider, and you can do a time series, and you can find out what's actually happening. So that gave a wealth of insight, and that actually changed the way services were delivered, the way managers were monitoring, and that actually changed the health outcome, because it is universal. If you increase the number of NCs, the health outcome will change. So what was the aftermath? It's not. Can you please check what happened?
Can you reload the slide, please?
Anyways, let me continue as the slide comes up. The aftermath was, once we did the study and shared the result with the stakeholders, SLAB, Saving Lives at Birth, allocated $2 million to scale up the whole thing with BRAC TTS. BRAC TTS, that's transition to scale. It was a 3 years program, and this time it's going rural, marginalized women, and with 850 community health workers of BRAC. And now this is something we expected to replicate the outcome. And what happened that BRAC HNPP, they revamped the whole eHealth platform and moved to mHealth, and the project launched. They equipped their 4,300 community health workers with mHealth app and tab, and this time Simprints was used in 32 districts. Unfortunately, within 3 months of the project started, we were hit by COVID. So there was pandemic, lockdown, and change service delivery protocol to make sure that the community health worker and also the beneficiaries are, safer. As a result, we couldn't reach a million, but we reached at least more than 850,000 women of reproductive age across 32 districts of rural Bangladesh. And we have ensured that more than 360,000 verified services were delivered. These services delivered through biometric verification. So that means there's no question of this service delivery. An impact study is already going on with James P. Grant School of Public Health. So we are hoping to share the findings of this impact study maybe in the next BIGD conference. So with that, I'll conclude my part, and thank you so much.
Thank you. 3.5 minutes to spare, so it's very nice. Great. I think through three great presentation. The first one I'm a little bit very excited about because it's about mental health and well, part of it is mental health, but actually taking advantage of gamification and smartphone devices and app technology to reach out to individuals or beneficiaries who are typically a little difficult to get hold of. There are a lot of interest around mental health, and I believe I don't have any scientific data, but I think people are opening up more to seeking mental health care. Still, there are a lot of stigma around, so this kind of private device can probably take advantage of that. The second presentation, a set of presentation, I think I would really like to congratulate because the type of research there, like actually thinking through policy analysis and what are the gaps there. It seems that Colombia is in somewhat lucky to have loopholes in some existing policies where we are still yet to have policies. So we'll probably have those loopholes in the beginning, eventually. But it seems there are a lot of cross learning, and it's also nice to see that within these two very different contexts, very similar types of problems emerge. For example, gender gap, attitude toward marginalized individuals within the society, the same apprehension toward lack of security and privacy that always coming up with this kind of approaches, especially delivering healthcare through digital means. And lastly, thanks to Nalva, I think this is a fantastic area to work with because there are a lot of gaps in terms of identifying individuals. And there's a, if I borrow that term from Amartya Sen, like missing not women, but missing population. And unless we have some way to track them, how can we ensure we deliver healthcare, which is like a fundamental human right and a responsibility and duty of the state. So perhaps we can, how much time can you allow us for some open discussion? Maybe 10 minutes, we can take 10 minutes and maybe a few questions. Otherwise, yes. Please mention who you are and then fire away. I'll take the opportunity to stand up because organizer, this is not very physically healthy.
Okay, thank you. I'm Jahid and I'm from BIGD. So my question is directed to Dr. Munshi. So we know that in a country like Bangladesh, adolescents, the access of digital devices for adolescents is reliant on parents, especially in the rural areas. So if a game like Kwamsha is ever to develop in our country, how parents are going to be involved in the whole process? Is there any, can you comment on that? So yeah, thank you.
Thank you. It seems like we have actually two questions, like how to bring your amazing approach to Bangladesh. So please.
I mean, of course, personally, I am interested and curious to see how the sort of same principles and ideas and possibly some of the same storylines can be brought in and basically translate it into Bangla. Currently, we have it in two versions, in English and Luganda. Um, let's see what happens on that. But on the second question about parental engagement. So what are the parental worries? I mean, even in the feasibility study, we had to look into those. So the parental worries are, what are they looking into? Are they going beyond, like, earlier today, people talked about if the girls are using, they're probably, having romance. And for boys, the worries are maybe they're going into sites that undesirable, sort of, porn sites and etc. So the way we had to engage parents is basically saying, as much as possible, we lock access to certain contents that they should not be allowed to. But that's kind of part of parents being aware in general about how to limit their access to it. But in particular to that app, because the adolescents can be sort of doing whatever, and then parents catch them. What are you doing? I'm doing the app. So prevent that, we also put timestamp, like they can run the app only for certain amount of time in a day, in a week, so that it's also not. I mean, we don't want them to sort of go through the app, finish it, and then forget it. We want them to sort of let the messages sink in and also spend little time at a go. So these are all embedded. The other issue is, like, I mean, one thing when we're designing, these are all text based. Someone has to be able to read and write. So that's part of our eligibility criteria. So obviously that's not going to, so this app is not applicable for many, in Uganda at least. But in Bangladesh, we have a better literacy rate. But I mean, this is not solution for everything, right? But this, if it works, and if we do find that this makes changes, this can work for a large number of population. That's what we are sort of aiming at.
So we have a question for Nail Bhai from Tariq Hassan. Is there ethical clearance needed from the government side to take fingerprint in SIMPRINT study? I have a bit of a follow-up to that. Given everything else is going on in Bangladesh, especially from the government side, for example, birth registration and whatnot, do you have in future, like how you see yourself or see your technology to be embedded with the government, how you're planning to work with the government? Because many of what you're doing, it seems like something that the government of Bangladesh, especially the DG Health, or who are in charge of working in this area, should be interested in as well. So I was just wondering, what's your thought on that?
Sure, thank you. I think for any study, we need that approval, and for biometrics, definitely, it's better to have approval from any authority that is relevant, because we still don't have the relevant policies or laws regarding this. Only Digital Security Act for this type of data collection. And I guess that answers the first one. And the second one, what you said, we're already in discussion with government. We have a MOU with ICT division. We're discussing closely with DGHS for a different project. And to clarify one thing, we are a non-profit technology company. We don't have any data business. So whatever data is collected, owner is the organization with whom we're working. So we just help in processing the data. We don't control the data. So and we are also GDPR compliant. So for us, it's not an issue, but the challenge is when the area is gray, because there is no legislation and it is subject to interpretation of different people. That is the challenging part. So we are trying to create that awareness, and see how we can work with government. And in future, we do see that working with the government, because there are multiple reasons. As we are, again, a non-profit, we use ISO standards, so it's interoperable. So these are built in with our system. So if we are doing something with government, and maybe a few years later government thinks, okay, fine, we'll try with someone else, it's very much possible. There's no vendor lock-in. So this type of practices we are already doing, and it's built in our, let's say, organization's DNA. So to create that awareness within the government, that's one of the things we are working on. Does that answer your question?
It does.
Thank you.
But I think, yeah, there actually that brings also to the work that Misha and Javier did in the two respective countries. Because Misha, maybe you can comment on, like, for example, from the policy point of view, and both two of you can even have a conversation. We don't have much time, but like what kind of policies or lack thereof can facilitate, for example, scaling up and making it a standard operating procedure to, for example, using our thumbprint, because again, we all are concerned about our privacy and data security. So, Misha, would you like to comment anything? For example, since you've been looking into policies.
So yeah, as I mentioned, like there is no policies at this moment that takes care of digital health data. So the question is, who owns the data? Is the clients, they own the data, government, the NGOs, or the private organizations that are provided these services? So as he mentioned, it's still a vague area, and we need, so one hope is maybe the upcoming national digital health strategy will have something along these lines. But then again, we don't know whether they have it. As I mentioned, like we still don't know what's in it and what's not in it. But that's definitely a concern.
Participate in writing that policy ourselves, like we are the
Oh,
expert. You're the
yeah.
expert.
So we are designing this, we are drafting this inception report where we are raising these concerns, like about digital health data, the rights of the beneficiaries or the client data. So we are raising this concern, and as I mentioned, like after we conduct the digital ethnography and ethnographic field research, along with this review, we will share a set of recommendation at the national level and also a global platform where we will compare like multi-country case studies, and so that, you know, we can make people aware of this issue, which, to be honest, even I was not aware of. Like we share information on digital platform, and some of them are health information at times. Like since the pandemic started, we are taking some digital health services, right? Like from video consultation or putting data on the, creating a portfolio or something. But we don't know who owns the data, whether they will be using my data, my sensitive data with someone else, where they will hide my identity, or we have no idea. I wasn't even aware of it, but since we started it, now I'll think twice. But still, yeah, this is an issue that we need to work on. Thank you.
Great. So we probably don't have any question, but Javier, are you there? I just wanted to ask you one last question. So since you've been working with the team from Bangladesh, is there anything that you learned about Bangladesh that like surprise in this particular area, like you would really be excited about, or anything that
No, I think probably what I was excited and found really interesting is the commonalities. Like because we obviously have like really different cultural backgrounds and history, but it seems like both countries are trying to harness digital, like countries and obviously private companies are trying to harness the power of digital and building policies and stuff, but not really thinking on the consequences, what will happen with the data and that kind of stuff. And also not taking into account the whole population in building the policies, and not just building the policies, in building the technologies. Because sometimes our technology is built for particular people, like people living with HIV, but not taking into account the local experiences and the situated experiences of people living with HIV. So I found that commonality is really striking, like in these really different settings, cultural settings, religions, and stuff. It seems like really similar. The power of digital is taking hold of everything without taking into account the situated issues and problems.
Sure. That's actually a really great point. So unless there's any other question from the physical floor or virtual floor, we can bring it to conclusion. Thanks so much for presenting, all 4 presenters, and thanks for coming here. So I conclude this session. Thank you so much.